Welcome to this video entitled Thyroid Disorders. Thyroid hormone synthesis is a fascinating process that takes place inside the thyroid gland's tiny spherical structures called follicles. These follicles contain a protein-rich substance known as colloid, where thyroid hormones are actually produced and stored. The two main thyroid hormones are thyroxine, also called T4, and triiodothyronine, known as T3. Although T4 is produced in larger amounts, T3 is the more biologically active hormone at the tissue level. The entire synthesis process begins with iodide trapping. Dietary iodine is absorbed from food and enters the bloodstream mainly as iodide. Thyroid follicular cells actively pull iodide from the blood using a specialized transporter called the sodium iodide symporter, or NIS. This transporter is located on the basolateral membrane of the follicular cell, which faces the bloodstream. Sodium iodide symporter uses the sodium gradient to move iodide into the cell against its concentration gradient. This step is extremely important because the thyroid gland requires large amounts of iodine to produce thyroid hormones. Once inside the follicular cell, iodide moves toward the follicular lumen, where hormone synthesis occurs on a large protein called thyroglobulin, or Tg. Thyroglobulin acts like a scaffold that holds tyrosine residues used for hormone production. The next key enzyme is thyroid peroxidase, commonly called TPO. Thyroid peroxidase performs several essential reactions in thyroid hormone synthesis. First, it oxidizes iodide into a more reactive iodine form. Then, thyroid peroxidase catalyzes organification, which means iodine becomes attached to tyrosine residues on thyroglobulin. When one iodine molecule attaches to tyrosine, the product is called monoiodotyrosine, or MIT. When two iodine molecules attach, it forms diiodotyrosine, or DIT. These iodinated tyrosines are the building blocks for thyroid hormones. The final major step is coupling. Thyroid peroxidase links different iodotyrosine molecules together while they remain attached to thyroglobulin. Coupling of one monoiodotyrosine and one diiodotyrosine produces T3. Coupling of two diiodotyrosine molecules produces T4. These hormones remain stored within thyroglobulin in the colloid until the body needs them. When stimulated by thyroid-stimulating hormone, or TSH, the follicular cells take up thyroglobulin from the colloid and break it down inside lysosomes. This releases free T3 and T4 into the bloodstream. Once released, thyroid hormones regulate metabolism, growth, oxygen consumption, heat production, and many other vital body functions. So, thyroid hormone synthesis is a carefully coordinated process involving iodide transport, thyroid peroxidase-mediated iodination, and coupling reactions occurring on thyroglobulin within the thyroid follicle itself. Although the thyroid gland releases both T4 and T3, most circulating thyroid hormone is actually T4. However, T4 is not the most biologically active form. T4 mainly acts as a pro-hormone, meaning it serves as a precursor that must be converted into the more active hormone T3. This conversion happens in peripheral tissues throughout the body. The process is controlled by specialized enzymes called diadinases. These enzymes remove iodine atoms from thyroid hormones and determine whether the hormone becomes activated or inactivated. There are three major diadinases: D1, D2, and D3. Type 1 diadinase, or D1, is found mainly in the liver, kidneys, and thyroid gland. D1 converts T4 into active T3 and contributes significantly to circulating T3 levels in the bloodstream. Type 2 diadenus, called D2, is especially important in the brain, pituitary gland, brown adipose tissue, and skeletal muscle. D2 also converts T4 into active T3, but its role is more focused on local tissue regulation. This allows individual organs to control their own thyroid hormone activity even when blood hormone levels fluctuate. D2 is particularly critical in the hypothalamic pituitary thyroid axis, also called the HPT axis. Inside the brain and pituitary gland, D2 helps maintain proper thyroid hormone sensing and hormonal feedback control. In simple terms, D2 helps the brain determine whether the body has enough thyroid hormone. This process is essential for maintaining the hypothalamic pituitary thyroid axis set point, which regulates TSH secretion and overall thyroid balance. The third enzyme, D3, works differently. Instead of activating thyroid hormone, D3 inactivates it. D3 converts T4 into reverse T3, also called RT3. Reverse T3 is biologically inactive and does not stimulate thyroid hormone receptors effectively. D3 can also convert T3 into inactive metabolites, reducing thyroid hormone activity within tissues. This becomes especially important during illness, fasting, or severe physiologic stress, when the body may intentionally reduce active thyroid hormone signaling. Another important detail is that all diadenases are selenoenzymes. That means they require selenium as an essential cofactor for proper function. Selenium is incorporated directly into the active site of these enzymes, allowing them to carry out iodine removal reactions efficiently. Without adequate selenium, thyroid hormone metabolism and conversion may become impaired. So, thyroid hormone activity depends not only on how much hormone the thyroid gland produces, but also on how effectively peripheral tissues convert T4 into active or inactive forms. Diadenases act like metabolic regulators, fine-tuning thyroid hormone activity throughout the body and helping maintain stable endocrine balance. The regulation of thyroid hormones depends on a carefully controlled endocrine feedback system called the hypothalamic pituitary thyroid axis, or HPT axis. This system constantly monitors thyroid hormone levels and adjusts hormone production to maintain metabolic balance throughout the body. Everything begins in the hypothalamus, a regulatory center located in the brain. The hypothalamus releases thyrotropin-releasing hormone, commonly called TRH. Thyrotropin-releasing hormone then travels to the anterior pituitary gland and stimulates the release of thyroid-stimulating hormone, or TSH. Thyroid-stimulating hormone acts directly on the thyroid gland and serves as the main driver of thyroid hormone synthesis and release. When thyroid-stimulating hormone binds to thyroid follicular cells, it stimulates iodide uptake, thyroglobulin production, thyroid peroxidase activity, and the release of T3 and T4 into the bloodstream. As thyroid hormone levels rise, the body activates a negative feedback mechanism. Free T3 and free T4 signal back to both the hypothalamus and pituitary gland to suppress further thyrotropin-releasing hormone and thyroid-stimulating hormone production. This feedback loop helps prevent excessive thyroid hormone production and keeps metabolism within a stable physiologic range. In simple terms, low thyroid hormone levels increase thyroid-stimulating hormone release, while high thyroid hormone levels suppress it. This is why thyroid-stimulating hormone is such an important laboratory marker for evaluating thyroid function. Another important concept is thyroid hormone transport in the bloodstream. Although large amounts of T4 and T3 circulate in blood, more than 99% are actually bound to transport proteins. The main binding protein is thyroxine-binding globulin, also known as TBG. Other proteins such as albumin and transthyretin also help transport thyroid hormones throughout the circulation. Protein binding acts like a storage reservoir for thyroid hormones. Bound hormones remain inactive while circulating through the bloodstream. Only a tiny fraction of thyroid hormone exists in the free, unbound state. This free fraction is the biologically active portion that can enter cells and bind thyroid hormone receptors. Free T3 is especially potent because it directly regulates gene transcription and cellular metabolism. Changes in binding proteins can alter total thyroid hormone levels without necessarily changing thyroid function itself. For example, pregnancy and estrogen therapy increase thyroxine-binding globulin levels, which may raise total T4 concentrations even when free hormone levels remain normal. That is why clinicians often measure free T4 and thyroid-stimulating hormone together when assessing thyroid status. The hypothalamic pituitary thyroid axis and thyroid transport proteins work together to maintain stable hormone availability throughout the body. This balance ensures that tissues receive enough active thyroid hormone to regulate metabolism, energy production, temperature control, growth, and neurologic function without allowing hormone levels to become dangerously excessive. Hypothyroidism occurs when the body does not produce enough thyroid hormone to meet normal metabolic demands. Because thyroid hormones regulate energy production, temperature control, and cellular metabolism, deficiency can slow down many body functions. The most common cause of hypothyroidism worldwide in iodine-sufficient regions is Hashimoto thyroiditis. Hashimoto disease is an autoimmune disorder in which the immune system mistakenly attacks the thyroid gland. Over time, chronic inflammation gradually destroys thyroid follicular cells and reduces hormone production. One major immune target is thyroid peroxidase, also called TPO. Many patients develop anti-thyroid peroxidase antibodies, which are important laboratory markers for autoimmune thyroid disease. As thyroid tissue becomes progressively damaged, the gland loses its ability to produce adequate T4 and T3. In the early stages, the pituitary gland compensates by increasing TSH secretion to stimulate the failing thyroid. Eventually, however, thyroid hormone production continues to decline despite elevated TSH levels. Patients may then develop fatigue, weight gain, cold intolerance, constipation, dry skin, and slowed mental function. Hypothyroidism can also develop from iatrogenic causes, meaning it results from medical treatment or intervention. One common example is radioactive iodine therapy. Radioactive iodine is often used to treat hyperthyroidism because thyroid cells naturally concentrate iodine. However, this treatment may permanently damage thyroid tissue and lead to long-term hormone deficiency. Surgical removal of the thyroid gland, called thyroidectomy, can also produce hypothyroidism if too much functioning tissue is removed. Certain medications may impair thyroid hormone synthesis as well. Drugs such as lithium, amiodarone, and some immunotherapies can interfere with thyroid function and trigger hypothyroidism in susceptible patients. Another important category is central hypothyroidism. Unlike primary hypothyroidism, where the thyroid gland itself fails, central hypothyroidism results from dysfunction of the pituitary gland or hypothalamus. In these cases, The thyroid gland may actually be structurally normal. The problem is inadequate stimulation from the brain. If the pituitary cannot produce enough TSH, or the hypothalamus cannot produce enough TRH, thyroid hormone production falls. Laboratory testing typically shows both low TSH and low T4 levels. This pattern differs from primary hypothyroidism, where TSH is usually elevated. A rare but fascinating cause is consumptive hypothyroidism. This occurs when certain tumors overexpress type 3 diadinus, also called D3. D3 inactivates thyroid hormones by converting T4 into reverse T3 and degrading active T3. When tumor D3 activity becomes excessive, thyroid hormones are destroyed faster than the body can replace them. As a result, patients may develop profound hypothyroidism despite a normally functioning thyroid gland. So, hypothyroidism can result from autoimmune destruction, medical treatment, impaired brain signaling, or even excessive peripheral hormone inactivation. Despite these different mechanisms, the final outcome is reduced thyroid hormone activity and slowing of normal metabolic function throughout the body. Hyperthyroidism occurs when the body is exposed to excessive thyroid hormone activity. This accelerates metabolism and can affect nearly every organ system in the body. One of the most common causes is Graves' disease, an autoimmune disorder affecting the thyroid gland. In Graves' disease, the immune system produces abnormal antibodies called thyroid-stimulating immunoglobulins, or TSI. These antibodies bind to and activate the TSH receptor on thyroid follicular cells. Normally, the TSH receptor is stimulated only by pituitary TSH. But in Graves' disease, thyroid-stimulating immunoglobulins continuously stimulates the receptor even when TSH levels are already low. This causes uncontrolled thyroid hormone synthesis and release. The thyroid gland enlarges diffusely, producing a toxic diffuse goiter. Patients may develop weight loss, heat intolerance, tremors, anxiety, palpitations, and excessive sweating because metabolism becomes excessively accelerated. Graves' disease can also produce unique findings such as ophthalmopathy and pretibial myxedema due to autoimmune tissue inflammation outside the thyroid gland. Another important cause of hyperthyroidism involves toxic adenomas and toxic multinodular goiters. These conditions often arise from somatic gain-of-function mutations in the TSH receptor gene, also called TSHR. These mutations make thyroid cells function autonomously. In other words, the mutated thyroid tissue no longer depends on pituitary TSH stimulation. The affected nodules continuously produce thyroid hormones on their own. Over time, autonomous hormone production suppresses pituitary TSH secretion through negative feedback. Unlike Graves' disease, toxic nodules are usually focal rather than diffuse processes. Thyroiditis can also produce thyrotoxicosis, but through a very different mechanism. In thyroiditis, inflammation damages thyroid follicular cells and causes leakage of preformed thyroid hormones into the bloodstream. Importantly, the gland is not actively overproducing hormone. Instead, stored hormones simply spill out as thyroid tissue becomes inflamed or damaged. This creates a transient thyrotoxic phase that often resolves once hormone stores become depleted. Because synthesis is not increased, radioactive iodine uptake is typically low in thyroiditis-associated thyrotoxicosis. Another interesting endocrine pattern occurs during severe systemic illness and is called non-thyroidal illness syndrome, or low T3 syndrome. This condition is common in critically ill patients. In these cases, Thyroid hormone metabolism changes dramatically even though the thyroid gland itself may be normal. Peripheral conversion of T4 to active T3 decreases, while conversion to reverse T3 increases. As a result, laboratory testing often shows low T3 levels together with elevated reverse T3, or RT3. This shift is thought to represent an adaptive metabolic response during severe illness, trauma, or starvation. So, hyperthyroid states can arise from autoimmune receptor stimulation, autonomous thyroid mutations, inflammatory hormone leakage, or altered peripheral hormone metabolism during critical illness. Thyroid disorders can dramatically affect the body because thyroid hormones regulate metabolism, energy production, heart function, temperature control, and even neurologic activity. When thyroid hormone levels become too high or too low, patients develop very characteristic clinical symptoms. In hyperthyroidism, the body essentially enters a hypermetabolic state. Metabolism accelerates, and many organ systems become overstimulated. One of the most common symptoms is tachycardia. The heart beats faster and more forcefully because thyroid hormones increase sensitivity to catecholamines like epinephrine. Patients may experience palpitations, anxiety, and even atrial fibrillation in severe cases. Heat intolerance is another hallmark feature. Because metabolism is elevated, the body produces excessive heat, causing patients to feel unusually warm and sweaty even in normal environments. Weight loss commonly occurs despite a normal or increased appetite because the body burns calories rapidly. Fine tremors are also very characteristic. These tremors result from increased sympathetic nervous system activity and heightened neuromuscular excitability. Graves' disease, the most common autoimmune cause of hyperthyroidism, can produce several unique physical findings. One classic sign is exophthalmos, where the eyes appear to protrude forward. This occurs because autoimmune inflammation and glycosaminoglycan deposition develop behind the eyes within the orbital tissues. Patients may experience eye irritation, dryness, double vision, or difficulty closing their eyelids completely. Pretibial myxedema is another Graves-specific finding. In this condition, thickened skin develops over the shins due to accumulation of glycosaminoglycans in the dermis. The skin may appear waxy, swollen, or discolored. A much rarer finding is thyroid acropathy. This involves soft tissue swelling and clubbing of the fingers and toes associated with autoimmune thyroid disease. Hypothyroidism produces almost the opposite physiologic picture. Instead of accelerated metabolism, body functions begin to slow down. Patients commonly develop fatigue, lethargy, and reduced exercise tolerance. Cold intolerance occurs because the body generates less heat as metabolic activity declines. Bradycardia is also common because thyroid hormone deficiency reduces cardiac stimulation and slows heart rate. Another classic examination finding is delayed relaxation of deep tendon reflexes. The reflex contraction may occur normally, but the muscle relaxes more slowly afterward. This finding reflects slowed neuromuscular function in hypothyroidism. Severe untreated hypothyroidism can progress to myxedema coma, which is a medical emergency. Despite the name, patients may not always be completely comatose initially, but they often develop profound mental status changes, confusion, hypothermia, bradycardia, and respiratory depression. Myxedema coma represents extreme metabolic failure caused by severe thyroid hormone deficiency. Without rapid treatment, it can become fatal. So, thyroid disorders create two opposite metabolic states. Hyperthyroidism accelerates body function, while hypothyroidism slows nearly every physiologic process in the body. Diagnosing thyroid disorders begins with understanding how tightly the hypothalamic pituitary thyroid axis regulates hormone levels. Even small changes in thyroid function can produce noticeable shifts in pituitary signaling. Because of this sensitive feedback system, serum TSH is considered the most sensitive screening test for primary thyroid disorders. In primary hypothyroidism, the failing thyroid gland produces less thyroid hormone. The pituitary responds by increasing TSH secretion in an attempt to stimulate the thyroid gland harder. As a result, TSH levels become elevated, often before symptoms become obvious. In primary hyperthyroidism, the opposite occurs. Excess thyroid hormone strongly suppresses pituitary TSH release through negative feedback. This causes TSH levels to become very low or even undetectable. That is why TSH is often the first and most useful laboratory test ordered during thyroid evaluation. However, TSH alone does not provide the full picture. Free T4 measurement is used to confirm the diagnosis and assess disease severity. Free T4 represents the biologically active unbound hormone circulating in the bloodstream. This test helps distinguish subclinical disease from overt thyroid dysfunction. For example, in subclinical hypothyroidism, TSH may already be elevated while free T4 remains within the normal range. In overt hypothyroidism, both elevated TSH and low free T4 are present. Similarly, overt hyperthyroidism usually shows suppressed TSH together with elevated free T4 or free T3 levels. Another important diagnostic tool is radioactive iodine uptake testing, commonly called RAIU. The thyroid gland naturally concentrates iodine to produce thyroid hormones. Radioactive iodine uptake testing measures how actively the gland takes up radioactive iodine from the bloodstream. This helps determine whether thyrotoxicosis is caused by true hormone overproduction or by release of preformed hormones. In Graves' disease or toxic nodules, the thyroid gland is hyperfunctioning and actively synthesizing hormone, so radioactive iodine uptake becomes elevated. In thyroiditis, however, damaged follicular cells simply leak stored hormones into circulation. Since new hormone synthesis is not increased, radioactive iodine uptake remains low. This distinction is extremely important because treatment strategies differ significantly between these conditions. When thyroid nodules are discovered, evaluation focuses on determining whether malignancy may be present. The gold standard diagnostic procedure for suspicious thyroid nodules is fine needle aspiration, also called FNA. During fine needle aspiration, a thin needle is inserted into the thyroid nodule to collect cellular material for cytologic examination. This minimally invasive procedure helps distinguish benign nodules from thyroid cancers such as papillary thyroid carcinoma. Ultrasound guidance is often used to improve accuracy, especially for small or complex nodules. So, thyroid evaluation combines hormonal testing, physiologic imaging, and tissue sampling. TSH screens for dysfunction, free T4 confirms disease severity, radioactive iodine uptake identifies the mechanism of thyrotoxicosis, and fine needle aspiration helps diagnose potentially malignant thyroid nodules. The main goal of hypothyroidism treatment is simple: restore normal thyroid hormone levels and return metabolism to a healthy balance. The drug of choice for most patients is levothyroxine, also called LT4. Levothyroxine is a synthetic form of thyroxine, which is the same hormone naturally produced by the thyroid gland. One major advantage of levothyroxine is its long half-life, which is about 7 days in healthy adults. Because it remains in the bloodstream for a long time, hormone levels stay relatively stable with once-daily dosing. This stability makes levothyroxine highly effective for long-term thyroid hormone replacement. After absorption, much of the administered T4 is converted in peripheral tissues into active T3 through deiodinase enzymes. This allows the body to regulate tissue-level thyroid activity naturally. Proper absorption of levothyroxine is extremely important for successful treatment. The medication is best absorbed in the small intestine when taken on an empty stomach. Several common substances can interfere with absorption and reduce treatment effectiveness. Calcium supplements are a major example. Calcium can bind levothyroxine in the gastrointestinal tract and prevent proper absorption. Iron supplements can cause similar problems. Aluminum-containing antacids and certain proton pump inhibitors may also impair absorption or alter stomach acidity enough to affect medication uptake. Because of these interactions, patients are usually advised to take levothyroxine separately from interfering medications or supplements by several hours. Monitoring treatment response is important because even small dose changes can significantly affect thyroid hormone balance. TSH levels are commonly followed to guide dose adjustments and confirm adequate replacement therapy. Special caution is required in older adults and patients with cardiovascular disease. Thyroid hormones increase heart rate, myocardial oxygen demand, and cardiac workload. If replacement therapy is started too aggressively in elderly patients, it can trigger angina, arrhythmias, or myocardial ischemia. That is why clinicians often follow the start low, go slow approach in geriatric patients. Initial doses may begin as low as 12.5 to 25 micrograms daily, followed by gradual dose increases over time. This allows the cardiovascular system to adapt safely to increasing metabolic activity. Another important clinical point involves medication consistency. Different manufacturers and formulations may have small variations in bioavailability. Even subtle differences in absorption can cause fluctuations in TSH levels and alter thyroid control. For this reason, patients are usually encouraged to remain on the same brand or generic formulation whenever possible. If a formulation change becomes necessary, repeat thyroid function testing may be needed to ensure hormone levels remain stable. With proper dosing, consistent administration, and regular monitoring, levothyroxine therapy can effectively restore normal metabolism and greatly improve symptoms of hypothyroidism. Hyperthyroidism occurs when the thyroid gland produces excessive thyroid hormones, causing the body's metabolism to speed up dramatically. Patients may develop palpitations, tremors, weight loss, heat intolerance, anxiety, and excessive sweating because nearly every organ system becomes overstimulated. One of the main treatment approaches involves medications called thionamides. The two major thionamides are methimazole and propylthiouracil, commonly called PTU. Both medications work by blocking thyroid hormone synthesis inside the thyroid gland. They specifically inhibit thyroid peroxidase, also known as TPO. Thyroid peroxidase is essential for iodide oxidation, organification, and coupling reactions during thyroid hormone production. By inhibiting thyroid peroxidase, thionamides reduce the formation of both T3 and T4. Over time, this lowers circulating thyroid hormone levels and helps restore metabolic balance. Methimazole is generally the preferred medication for most patients. One major reason is its lower toxicity profile compared with propylthiouracil. Methimazole also has a longer duration of action, allowing convenient once-daily dosing in many cases. This improves treatment adherence and simplifies long-term management. However, there are two important situations where propylthiouracil is preferred instead. The first is during the first trimester of pregnancy. Methimazole has been associated with rare congenital malformations when used early in fetal development. Because of this, propylthiouracil is usually favored during early pregnancy despite its own risks. After the first trimester, many patients are switched back to methimazole because propylthiouracil carries a higher risk of liver toxicity. The second major indication for propylthiouracil is thyroid storm, which is a severe and life-threatening form of hyperthyroidism. In addition to blocking new thyroid hormone synthesis, propylthiouracil also decreases peripheral conversion of T4 into the more active T3. This additional effect can help lower active thyroid hormone levels more rapidly during emergencies. Although thionamides are highly effective, clinicians must monitor for potentially serious adverse effects. One of the most dangerous complications is agranulocytosis. This is a rare but life-threatening condition in which neutrophil levels drop dramatically, leaving the patient highly vulnerable to severe infections. Patients may suddenly develop fever, sore throat, mouth ulcers, or signs of systemic infection. If these symptoms occur, the medication should be stopped immediately and a complete blood count, or CBC, must be obtained urgently. Early recognition is critical because untreated agranulocytosis can rapidly become fatal. Liver toxicity is another important concern, especially with propylthiouracil. Because of these risks, regular clinical follow-up and patient education are essential during treatment. So, thionamides remain a cornerstone of hyperthyroidism management because they directly block thyroid hormone synthesis, but careful monitoring is necessary to ensure safe and effective therapy. Pregnancy creates major hormonal and metabolic changes throughout the body, and the thyroid gland must adapt to meet these increased physiologic demands. Thyroid hormones are especially important during pregnancy because they support maternal metabolism and are critical for normal fetal brain and nervous system development. In women with hypothyroidism, levothyroxine requirements often increase significantly during pregnancy. Most patients require about 30 to 50% more thyroid hormone replacement compared with pre-pregnancy dosing. Several physiologic changes contribute to this increased demand. Estrogen raises levels of thyroxine-binding globulin, also called TBG, which increases thyroid hormone binding in the bloodstream. At the same time, maternal metabolism accelerates and the developing fetus also depends partly on maternal thyroid hormone, especially during early pregnancy before the fetal thyroid gland becomes fully functional. Because thyroid hormone requirements can change quickly, close laboratory monitoring is essential. TSH levels are usually checked monthly during pregnancy to ensure adequate thyroid replacement. Clinicians generally aim to maintain TSH levels below about 2.5 million international units per liter during early pregnancy because even mild maternal hypothyroidism may affect fetal development. Careful dose adjustment helps maintain stable thyroid hormone availability for both mother and fetus. Hyperthyroidism during pregnancy also requires special management considerations. Thionamide medications are used to control excessive thyroid hormone production, but drug selection depends heavily on the stage of pregnancy. Propylthiouracil, or PTU, is usually preferred during the first trimester. This is because methimazole has been associated with rare congenital malformations known as methimazole embryopathy when exposure occurs during early fetal organ development. Although propylthiouracil carries its own risks, including potential liver toxicity, it is generally considered safer during the first trimester. After the first trimester, many patients are transitioned back to methimazole because prolonged propylthiouracil therapy increases the risk of hepatotoxicity. Another important thyroid condition related to pregnancy is postpartum thyroiditis, commonly called PPT. This disorder occurs after delivery and is thought to result from immune system rebound following pregnancy-related immune suppression. Postpartum thyroiditis often follows a biphasic pattern. Initially, inflammation damages thyroid follicular cells and causes leakage of preformed thyroid hormones into circulation. This creates a transient thyrotoxic phase with symptoms such as palpitations, anxiety, and heat intolerance. Because the gland is leaking stored hormone rather than actively overproducing it, this phase is usually temporary. As thyroid hormone stores become depleted, many patients then enter a hypothyroid phase. During this stage, fatigue, weight gain, cold intolerance, and low energy may develop. Some women eventually recover completely, while others progress to permanent hypothyroidism requiring long-term levothyroxine therapy. So, pregnancy and the postpartum period place unique demands on thyroid physiology, making careful monitoring and individualized treatment extremely important for maternal and fetal health. Thyroid emergencies are serious endocrine conditions that require rapid recognition and immediate treatment. One of the most dangerous examples is thyroid storm, which represents an extreme and life-threatening form of hyperthyroidism. In thyroid storm, the body becomes overwhelmed by excessive thyroid hormone activity. Patients may develop severe tachycardia, high fever, agitation, delirium, vomiting, heart failure, and even cardiovascular collapse. Without urgent treatment, thyroid storm carries a very high mortality rate. Management requires multiple therapies working together at different steps of thyroid hormone production and action. One major treatment group is thionamides, including propylthiouracil and methimazole. These medications inhibit thyroid peroxidase, also called TPO, which blocks new thyroid hormone synthesis inside the thyroid gland. Propylthiouracil, or PTU, is often preferred during thyroid storm because it also decreases peripheral conversion of T4 into the more active T3. This additional effect helps reduce active thyroid hormone levels more rapidly. Another important therapy is iodide administration, commonly given as Lugol solution or potassium iodide. Large doses of iodide temporarily block thyroid hormone release from the gland through a mechanism called the Wolff-Chaikoff effect. Iodides also reduce thyroid gland vascularity, which becomes especially useful before thyroid surgery because it decreases bleeding risk. Timing is important, however. Iodides should only be administered after thionamides have already blocked new hormone synthesis. Otherwise, the thyroid gland could potentially use the iodine to produce even more hormone. Beta blockers are also essential in thyroid storm management. Medications such as propranolol help control the intense adrenergic symptoms caused by excess thyroid hormone. They reduce tachycardia, tremors, palpitations, anxiety, and sympathetic overactivity. Propranolol has an additional benefit because it modestly inhibits peripheral conversion of T4 into T3. This helps lower biologically active thyroid hormone levels even further. Glucocorticoids are another critical part of treatment. They help stabilize the patient, reduce peripheral T4 to T3 conversion, and may also treat potential relative adrenal insufficiency during severe physiologic stress. Beyond emergency management, some patients require definitive treatment for hyperthyroidism. One common option is radioactive iodine therapy using iodine-131. Because thyroid cells naturally concentrate iodine, radioactive iodine selectively destroys overactive thyroid tissue over time. This therapy is especially effective for Graves' disease and toxic nodular hyperthyroidism. However, radioactive iodine is strictly contraindicated during pregnancy. Radioactive iodine can cross the placenta and damage the fetal thyroid gland, potentially causing permanent fetal hypothyroidism. For that reason, pregnancy testing is essential before treatment in women of reproductive age. So, thyroid emergencies require rapid, multi-step intervention targeting hormone synthesis, hormone release, peripheral hormone activation, and sympathetic overactivity all at the same time. Pediatric thyroid disorders are especially important because thyroid hormones play a critical role in growth, brain development, metabolism, and skeletal maturation during childhood. One of the most serious conditions is congenital hypothyroidism, often called CH. Congenital hypothyroidism occurs when a baby is born with inadequate thyroid hormone production. If left untreated, severe thyroid hormone deficiency during infancy can permanently impair brain development. In fact, congenital hypothyroidism is considered one of the leading preventable causes of intellectual disability worldwide. That is why newborn thyroid screening programs are so important. Early diagnosis allows treatment to begin before irreversible neurologic damage occurs. Most cases of congenital hypothyroidism are caused by thyroid dysgenesis. This accounts for roughly 80% of cases. Thyroid dysgenesis means the thyroid gland fails to develop normally during fetal life. In some infants, the gland develops in the wrong location, a condition called ectopy. In others, the thyroid gland may be severely underdeveloped or completely absent, which is known as atheriosis. Without adequate thyroid tissue, normal T4 and T3 production cannot occur. Affected infants may initially appear normal because maternal thyroid hormone crosses the placenta during pregnancy. However, symptoms gradually emerge after birth as maternal hormone levels decline. Signs may include prolonged jaundice, poor feeding, lethargy, constipation, hypotonia, macroglossia, and delayed growth. Prompt levothyroxine treatment is essential to support normal neurologic and physical development. Children can also develop hyperthyroidism, most commonly from Graves' disease. When antithyroid medications are needed in pediatric patients, methimazole is strongly preferred over propylthiouracil, also called PTU. The reason is safety. Propylthiouracil has been associated with rare but severe liver failure in children. Some cases have progressed to fulminant hepatic failure requiring liver transplantation. Because of this serious risk, propylthiouracil is generally avoided in pediatric hyperthyroidism except in very limited situations. Methimazole is considered safer and is usually the first-line thionamide for children and adolescents. Another important pediatric thyroid issue involves thyroid nodules. Although thyroid nodules are less common in children than adults, they carry a much higher risk of malignancy. In adults, most thyroid nodules are benign, but in children, approximately 25% of thyroid nodules may prove malignant. This higher cancer risk makes careful evaluation extremely important. Ultrasound imaging and fine needle aspiration are often used to assess suspicious nodules. Papillary thyroid carcinoma is the most common thyroid cancer seen in pediatric patients. Fortunately, children often respond very well to treatment, despite sometimes presenting with more advanced disease at diagnosis. So, pediatric thyroid disorders require rapid recognition and careful management because thyroid hormones are essential for normal growth, metabolism, and especially healthy brain development during childhood. Most thyroid disorders involve problems with hormone production, but some rare conditions show that normal thyroid hormone levels alone are not enough. The body must also transport hormones into cells and respond to them correctly at the receptor level. One important example is resistance to thyroid hormone beta, also called RTH-beta. In this condition, mutations affect the thyroid hormone receptor beta subtype. The body produces high levels of T4 and T3, but many tissues cannot respond normally to those hormones. Because the pituitary gland also becomes partially resistant to thyroid hormone feedback, TSH secretion is not fully suppressed. This creates a very unusual laboratory pattern. Patients often show elevated T4 and T3 together with a normal or even mildly elevated TSH. Under normal circumstances, high thyroid hormone levels should strongly suppress TSH. That mismatch is a key clue pointing toward hormone resistance rather than classic hyperthyroidism. Clinical symptoms can vary widely. Some tissues remain partially sensitive to thyroid hormone, while others are resistant. As a result, patients may show mixed features of both hyperthyroidism and hypothyroidism at the same time. Another rare disorder is resistance to thyroid hormone alpha, or RTH-alpha. This condition involves mutations affecting the thyroid hormone receptor alpha subtype. Unlike RTH-beta, laboratory testing may appear nearly normal. T4, T3, and TSH levels can fall close to the standard reference range, making diagnosis much more difficult. Despite relatively normal labs, patients often show clinical signs of hypothyroidism. They may develop constipation, delayed growth, fatigue, bradycardia, developmental delay, or cold intolerance because tissues relying heavily on alpha receptors cannot respond adequately to thyroid hormone. These disorders demonstrate that thyroid hormone action depends not only on hormone concentration, but also on receptor function within specific tissues. Another fascinating condition involves thyroid hormone transport rather than receptor signaling. MCT8 deficiency, also known as Allan-Herndon-Dudley syndrome, results from mutations affecting a cellular thyroid hormone transporter called monocarboxylate transporter 8, or MCT8. This transporter is especially important for moving thyroid hormone into neurons and brain tissue. Without proper transport, the developing nervous system cannot access adequate thyroid hormone, despite normal or elevated circulating hormone levels. Affected children develop severe psychomotor retardation, muscle weakness, movement disorders, and profound neurologic impairment. Laboratory testing often shows markedly elevated T3 levels because peripheral thyroid hormone metabolism becomes abnormal. This condition highlights how essential cellular transport systems are for proper endocrine function. Together, these disorders reveal an important endocrine principle. Hormone biology depends on much more than gland secretion alone. For thyroid hormones to function properly, they must circulate correctly, enter target cells efficiently, bind functional receptors, and activate tissue-specific signaling pathways throughout the body. Many medications can interfere with normal thyroid physiology and trigger either hypothyroidism or hyperthyroidism. These drug-induced thyroid disorders are important because symptoms may develop gradually and can easily be mistaken for progression of the underlying illness. One of the most famous examples is amiodarone. Amiodarone is a powerful antiarrhythmic medication commonly used to treat serious cardiac rhythm disorders. The drug contains extremely large amounts of iodine, and this has major effects on thyroid function. Amiodarone can cause two different forms of thyrotoxicosis. Type 1 amiodarone-induced thyrotoxicosis occurs when excess iodine stimulates increased thyroid hormone synthesis. This usually happens in patients with pre-existing thyroid disease, such as multinodular goiter or latent Graves' disease. In these patients, the thyroid gland uses the excess iodine as additional substrate for hormone production. Type 2 amiodarone-induced thyrotoxicosis is very different. In this form, amiodarone causes destructive thyroiditis. Inflammation damages thyroid follicular cells, causing leakage of preformed thyroid hormones into the bloodstream. So, type 1 involves increased synthesis, while type 2 involves destructive hormone release. Lithium is another medication strongly associated with thyroid dysfunction. Lithium is widely used in psychiatric treatment, especially for bipolar disorder. One major endocrine effect is inhibition of thyroid hormone release from the thyroid gland. Over time, this can lead to hypothyroidism in a significant number of patients, sometimes affecting up to 15% of individuals receiving chronic therapy. Patients may gradually develop fatigue, weight gain, cold intolerance, and elevated TSH levels. Because lithium therapy is often long-term, regular thyroid function monitoring is very important. Tyrosine kinase inhibitors, commonly called TKIs, are another major cause of thyroid dysfunction. These medications are widely used in cancer treatment. Drugs such as sunitinib can damage thyroid tissue, reduce thyroid vascularity, and impair normal gland function. Many patients eventually develop thyroid gland failure and hypothyroidism during therapy. In oncology patients, symptoms such as fatigue may easily be attributed to cancer itself, so thyroid testing becomes especially important. Another fascinating example is Beroten. Beroten is a retinoid medication used in certain malignancies, particularly cutaneous T-cell lymphoma. Unlike most thyroid disorders, Beroten causes central hypothyroidism rather than direct thyroid gland failure. It suppresses transcription of the TSH-beta gene in the pituitary gland. As TSH production falls, the thyroid gland receives inadequate stimulation and thyroid hormone levels decline. Laboratory testing may therefore show low TSH together with low free T4, which is characteristic of central hypothyroidism. These drug-induced disorders demonstrate how thyroid function can be disrupted at multiple levels, including hormone synthesis, hormone release, gland integrity, and even pituitary regulation. That is why careful thyroid monitoring is often necessary in patients receiving long-term or high-risk medications. Thyroid neoplasia refers to abnormal growths arising from thyroid tissue, ranging from slow-growing tumors to aggressive endocrine cancers. Understanding how these cancers spread and behave is critical for diagnosis and treatment. The most common thyroid malignancy is papillary thyroid cancer, often called PTC. Papillary thyroid cancer counts for the majority of thyroid cancer cases worldwide. It usually develops from thyroid follicular cells and tends to grow relatively slowly. One important feature of papillary thyroid cancer is its tendency to spread through lymphatic channels. Because of this, enlarged cervical lymph nodes are a common presentation. Even when lymph node metastases are present, the overall prognosis is often very favorable, especially in younger patients. Radiation exposure during childhood is a well-known risk factor for papillary thyroid carcinoma. Under the microscope, papillary thyroid cancer shows characteristic nuclear changes that help pathologists confirm the diagnosis. Another major type is follicular thyroid cancer, or FTC. Like papillary carcinoma, follicular thyroid cancer also arises from follicular thyroid cells. However, its pattern of spread is very different. Instead of spreading mainly through lymphatics, follicular carcinoma tends to spread hematogenously through the bloodstream. This allows distant metastases to develop more commonly in organs such as the lungs and bones. Patients may therefore present with bone pain, fractures, or pulmonary lesions if advanced disease is present. Diagnosis can sometimes be challenging because distinguishing follicular adenomas from carcinomas often requires evidence of capsular or vascular invasion. Medullary thyroid cancer, or MTC, is biologically very different from the previous two cancers. Medullary thyroid cancer arises from parafollicular C cells rather than follicular thyroid cells. These specialized neuroendocrine cells normally produce calcitonin, a hormone involved in calcium regulation. Many cases of medullary thyroid carcinoma are associated with mutations in the RET proto-oncogene. RET mutations may occur sporadically or as part of inherited syndromes such as multiple endocrine neoplasia type 2, also called MEN2. Because of this strong genetic association, family screening and genetic testing are extremely important in affected patients. Calcitonin serves as a major biomarker for medullary thyroid carcinoma. Elevated calcitonin levels may help support the diagnosis and monitor treatment response after surgery. Another useful biomarker is carcinoembryonic antigen, commonly called CEA. Rising carcinoembryonic antigen levels can indicate progressive or recurrent disease. Unlike many differentiated thyroid cancers, medullary thyroid carcinoma does not arise from iodine-concentrating follicular cells. As a result, radioactive iodine therapy is generally ineffective for medullary thyroid cancer. Overall, thyroid cancers differ greatly in their cellular origin, metastatic pathways, genetic drivers, and treatment approaches. Papillary carcinoma favors lymphatic spread, follicular carcinoma spreads through blood vessels, and medullary carcinoma originates from neuroendocrine C cells linked to RET mutations and calcitonin production. We will now progress to case review and self-assessment. This question focuses on one of the most important enzymes in thyroid hormone synthesis, thyroid peroxidase, commonly called TPO. The correct answer is B, thyroid peroxidase. To understand why, let's quickly walk through how the thyroid gland produces hormones. The thyroid gland cannot make T3 and T4 hormones without iodine. First, iodide is actively transported from the bloodstream into thyroid follicular cells. This transport step is carried out by the sodium iodide symporter, also called NIS. So, sodium iodide symporter helps bring iodide into the cell, but it does not chemically activate it. That is where thyroid peroxidase becomes essential. Thyroid peroxidase is located near the apical membrane of thyroid follicular cells facing the follicular lumen. Its first major job is oxidation of iodide. In this step, thyroid peroxidase converts iodide into a more reactive iodine form that can participate in hormone synthesis. Next comes organification, another process catalyzed by thyroid peroxidase. During organification, activated iodine binds to tyrosine residues on thyroglobulin, often abbreviated Tg. This produces monoiodotyrosine, or MIT, and diiodotyrosine, or DIT. Thyroid peroxidase then performs another critical function called coupling. Coupling joins MIT and DIT molecules together to form thyroid hormones. One MIT plus one DIT forms T3. Two DIT molecules combine to form T4. Without thyroid peroxidase, these essential reactions cannot occur efficiently, and thyroid hormone production falls dramatically. This is why thyroid peroxidase is such an important clinical target in endocrinology. Many autoimmune thyroid diseases involve antibodies directed against thyroid peroxidase. For example, Hashimoto thyroiditis commonly features anti-thyroid peroxidase antibodies that contribute to thyroid destruction. Thyroid peroxidase is also the target of antithyroid medications such as methimazole and propylthiouracil. These drugs inhibit thyroid peroxidase activity and reduce thyroid hormone synthesis in hyperthyroid patients. Now let's briefly look at why the other options are incorrect. Diadenous type 1 is involved in peripheral conversion of T4 into active T3 after hormones are already produced. It does not perform oxidation or organification inside the thyroid gland. The sodium iodide symporter transports iodide into the cell, but does not chemically modify it. Thyroglobulin acts as the protein scaffold where thyroid hormone synthesis occurs, but it is not the enzyme driving the reactions. So, the key enzyme responsible for oxidation and organification of iodide during thyroid hormone synthesis is thyroid peroxidase, making answer B the correct choice. This case highlights a very important principle in endocrinology and geriatric medicine. Thyroid hormone replacement must be started carefully in older patients with heart disease. The correct answer is C, 12.5 to 25 micrograms per day. Levothyroxine is the standard treatment for hypothyroidism because it replaces deficient T4 hormone and restores normal metabolism. However, thyroid hormones also increase cardiac activity. They raise heart rate, increase myocardial oxygen demand, and enhance sensitivity to catecholamines like epinephrine. In a healthy young patient, full replacement therapy may be started relatively quickly. But in elderly patients, especially those with coronary artery disease, aggressive dosing can be dangerous. If thyroid hormone levels rise too rapidly, the heart may suddenly require more oxygen than diseased coronary arteries can deliver. This mismatch can trigger myocardial ischemia, angina, arrhythmias, or even acute myocardial infarction. That is why clinicians follow the classic start low, go slow approach in older adults with cardiovascular disease. Instead of immediately giving full replacement doses, treatment begins with very small doses of levothyroxine. Typical starting doses range from 12.5 to 25 micrograms daily. The dose is then increased gradually over weeks to months while carefully monitoring symptoms, heart function, and laboratory values such as TSH and free T4. This slow titration allows the cardiovascular system to adapt safely to increasing metabolic demands. Now let's look at why the other answer choices are less appropriate. Option A, 1.6 micrograms per kilogram per day, represents the approximate full replacement dose commonly used in younger and otherwise healthy adults. For an elderly patient with coronary artery disease, this would likely be too aggressive initially. Option B, 50 micrograms daily, may still be excessive for someone with significant cardiac disease depending on their baseline condition and body size. Option D, 100 micrograms daily, would clearly risk precipitating serious cardiac complications in this setting. Another important point is that improvement in hypothyroid symptoms may occur gradually. Patients often begin to feel more energetic as treatment progresses, but overly rapid correction is not the goal in high-risk cardiac patients. Safety and careful titration are the priority. Clinicians also monitor TSH levels every several weeks because levothyroxine has a long half-life and steady-state hormone levels take time to stabilize. This case demonstrates how endocrine therapy must always be individualized to the patient. Even though levothyroxine is highly effective, dosing decisions depend heavily on age, cardiovascular status, and overall physiologic reserve. So, for a 72-year-old patient with coronary artery disease and hypothyroidism, the safest and most appropriate starting dose is 12.5 to 25 micrograms per day, making answer C correct. This question focuses on the management of hyperthyroidism during pregnancy, especially during the critical first trimester when fetal organ development is occurring. The correct answer is B, propylthiouracil, commonly called PTU. Treating hyperthyroidism in pregnancy requires balancing two priorities at the same time. The mother's thyroid hormone levels must be controlled safely, but fetal development must also be protected. Excess thyroid hormone during pregnancy can cause serious complications. Poorly controlled hyperthyroidism increases the risk of miscarriage, preeclampsia, maternal heart failure, preterm delivery, and fetal growth restriction. Because of these risks, treatment is often necessary. The main medications used are thionamides, which block thyroid hormone synthesis. Both methimazole and propylthiouracil inhibit thyroid peroxidase, also called TPO. This reduces production of T3 and T4 hormones inside the thyroid gland. However, drug selection changes during pregnancy because the medications have different safety profiles. During the first trimester, propylthiouracil is preferred. The reason involves fetal development. Methimazole has been associated with rare congenital malformations when exposure occurs early in pregnancy. These abnormalities are sometimes called methimazole embryopathy. Examples include scalp defects known as aplasia cutis and developmental abnormalities involving the esophagus or nasal passages. Because organogenesis occurs mainly during the first trimester, avoiding these fetal risks becomes especially important during early pregnancy. Propylthiouracil is therefore considered the safer option during this stage despite its own potential adverse effects. Another advantage of propylthiouracil is that it also decreases peripheral conversion of T4 into the more active T3 hormone. However, propylthiouracil is not completely risk-free. It carries a significant risk of hepatotoxicity, including rare cases of severe liver injury. For this reason, many patients are switched back to methimazole after the first trimester once the period of highest teratogenic risk has passed. Now let's briefly examine the incorrect options. Option A, methimazole, is generally the preferred thionamide outside pregnancy because it has lower liver toxicity and convenient once-daily dosing. But during the first trimester, propylthiouracil is safer for fetal development. Option C, radioactive iodine, is absolutely contraindicated in pregnancy. Radioactive iodine crosses the placenta and can destroy the fetal thyroid gland, potentially causing permanent fetal hypothyroidism. Option D, atenolol, is a beta blocker that may help control adrenergic symptoms such as tremor or tachycardia, but it does not treat the underlying excess thyroid hormone production. This case highlights an important endocrine principle. Treatment choices may change dramatically during pregnancy because fetal safety becomes a major consideration alongside maternal health. So, during the first trimester of pregnancy, the preferred medication for hyperthyroidism is propylthiouracil, making answer B correct. This case tests recognition of one of the most dangerous complications of antithyroid therapy. The correct answer is B. Perform a complete blood count, or CBC, to check for agranulocytosis. Methimazole is a thionamide medication commonly used to treat hyperthyroidism, especially Graves' disease. It works by inhibiting thyroid peroxidase, also called TPO, which blocks thyroid hormone synthesis inside the thyroid gland. Although methimazole is generally effective and well tolerated, it can rarely cause life-threatening adverse effects. One of the most serious complications is agranulocytosis. Agranulocytosis is a severe reduction in neutrophils, which are critical white blood cells responsible for fighting bacterial infections. When neutrophil levels fall dramatically, the immune system becomes dangerously weakened. Patients can rapidly develop severe infections that may progress to sepsis if not recognized quickly. The classic warning signs are sudden high fever and severe sore throat. These symptoms should immediately raise concern for agranulocytosis in any patient taking methimazole or propylthiouracil. Because this complication can progress rapidly, immediate evaluation is essential. A CBC is performed to measure the white blood cell count and specifically evaluate neutrophil levels. If agranulocytosis is confirmed, the medication must be stopped immediately. Patients may require hospitalization, protective infection management, broad-spectrum antibiotics, and supportive care depending on severity. This is why patients starting methimazole are often educated to seek urgent medical attention if they develop fever, sore throat, mouth ulcers, or signs of infection. Now let's briefly review why the other options are incorrect. Option A, increasing the methimazole dose, would be dangerous because the medication itself may be causing the problem. Option C, prescribing antibiotics alone, misses the underlying issue. Although infection may be present, the key priority is identifying possible agranulocytosis and stopping the offending medication. Option D, switching directly to propylthiouracil, is also inappropriate. Propylthiouracil is another thionamide and can also cause agranulocytosis. Because these drugs share similar mechanisms and toxicities, switching from one to the other after agranulocytosis is generally avoided. This case highlights an important pharmacology principle. Even medications commonly used in outpatient endocrine management can occasionally produce rare but life-threatening adverse reactions. Rapid recognition of warning symptoms is critical for patient safety. In clinical practice, fever plus sore throat in a patient taking methimazole should always trigger immediate concern for agranulocytosis until proven otherwise. So, the most appropriate immediate action is to perform a complete blood count to evaluate for agranulocytosis, making answer B correct. This question focuses on a very unusual thyroid laboratory pattern that does not follow the normal rules of endocrine feedback regulation. The correct answer is C, resistance to thyroid hormone, specifically RTH-beta. Under normal circumstances, high levels of T4 and T3 strongly suppress TSH secretion through negative feedback on the pituitary gland and hypothalamus. So normally, when thyroid hormone levels rise, TSH levels should become very low. That is exactly what happens in classic hyperthyroidism such as Graves' disease or toxic multinodular goiter. But in resistance to thyroid hormone beta, the situation is very different. This disorder is caused by mutations affecting the thyroid hormone receptor beta subtype. Because the receptor does not respond properly to thyroid hormones, many tissues become partially resistant to their effects. The pituitary gland is also affected by this resistance. As a result, the pituitary cannot fully sense the elevated thyroid hormone levels. Even though T4 and T3 are high, the pituitary continues producing TSH at normal or mildly elevated levels instead of suppressing it appropriately. This creates the classic laboratory pattern seen in RTH-beta, elevated T4 and T3 with an inappropriately normal or elevated TSH. That mismatch is the key clue in the question. Clinically, patients may have mixed symptoms because different tissues respond differently to thyroid hormones. Some organs remain relatively sensitive and may show signs of hyperthyroidism such as tachycardia or anxiety. Other tissues may behave as though thyroid hormone is deficient. This combination can make diagnosis challenging. Now let's look at why the other answer choices are incorrect. Option A, Graves' disease, causes true hyperthyroidism due to thyroid-stimulating immunoglobulins activating the TSH receptor. In Graves' disease, T4 and T3 rise, but TSH becomes strongly suppressed because feedback mechanisms are still functioning normally. Option B, Hashimoto thyroiditis, is primarily a cause of hypothyroidism due to autoimmune destruction of the thyroid gland. Patients usually develop elevated TSH with low thyroid hormone levels. Option D, toxic multinodular goiter, also causes true hyperthyroidism through autonomous hormone production by thyroid nodules. Like Graves' disease, TSH becomes suppressed because the pituitary still responds normally to excess thyroid hormone. This question highlights an important endocrine principle. Abnormal hormone levels do not always mean abnormal hormone production alone. Sometimes the problem lies in hormone signaling or receptor responsiveness. Resistance to thyroid hormone demonstrates that tissues must not only receive hormones, but also respond correctly to them at the cellular level. So, the condition characterized by elevated T4 and T3 together with an inappropriately normal or elevated TSH is resistance to thyroid hormone beta, making answer C correct. This question focuses on congenital hypothyroidism caused by dishormonogenesis, which means the thyroid gland is present but cannot produce hormones normally because of an enzyme defect. The correct answer is B, thyroid peroxidase defects. To understand this, let's first separate the two major categories of congenital hypothyroidism. The most common overall cause is thyroid dysgenesis, where the thyroid gland is absent, underdeveloped, or located in the wrong position. But this question specifically asks about dishormonogenesis. In dishormonogenesis, the thyroid gland exists, but one of the biochemical steps required for thyroid hormone synthesis is defective. Among these inherited synthesis disorders, defects in thyroid peroxidase, or TPO, are the most common cause. Thyroid peroxidase is an essential enzyme in thyroid hormone production. It performs several critical reactions inside the thyroid gland. First, thyroid peroxidase oxidizes iodide into an active iodine form. Next, it catalyzes organification, where iodine attaches to tyrosine residues on thyroglobulin. Finally, thyroid peroxidase helps couple iodinated molecules together to form T3 and T4 hormones. Without functional thyroid peroxidase, thyroid hormone synthesis becomes severely impaired. As thyroid hormone levels fall, The pituitary responds by increasing TSH secretion. Elevated TSH continuously stimulates the thyroid gland, often causing goiter formation even in infancy or childhood. Because these disorders are usually inherited in an autosomal recessive pattern, family history may sometimes be present. Early diagnosis is extremely important because untreated congenital hypothyroidism can lead to permanent intellectual disability and impaired growth. Fortunately, newborn screening programs allow early detection in many countries. Prompt levothyroxine treatment can dramatically improve developmental outcomes. Now let's briefly review the incorrect options. Option A, ectopic thyroid gland, is actually a form of thyroid dysgenesis rather than dyshormonogenesis. It involves abnormal thyroid gland location, not a hormone synthesis enzyme defect. Option C, MCT8 mutations, cause thyroid hormone transport disorders such as Allan-Herndon-Dudley syndrome. These conditions affect cellular transport of thyroid hormone rather than hormone synthesis itself. Option D, TSH receptor mutations, can impair thyroid stimulation, but they are not the most common cause of dyshormonogenesis. This question highlights an important endocrine principle. Normal thyroid function depends not only on the presence of the gland, but also on the integrity of multiple specialized enzymes involved in hormone synthesis. Among those enzymes, thyroid peroxidase plays one of the most central roles. So, the most common cause of congenital hypothyroidism due to dyshormonogenesis is a thyroid peroxidase defect, making answer B correct. This question focuses on the emergency treatment of thyroid storm and the important role of iodide therapy in controlling severe thyrotoxicosis. The correct answer is B, inhibiting the release of preformed thyroid hormone. Thyroid storm is a life-threatening endocrine emergency caused by extreme excess thyroid hormone activity. Patients may develop high fever, severe tachycardia, agitation, delirium, heart failure, and cardiovascular collapse. Because thyroid hormones affect nearly every organ system, rapid treatment is critical. One medication used in this setting is Lugol solution, which contains high concentrations of iodide. At first, this may sound confusing because iodine is normally required for thyroid hormone synthesis. However, when very large amounts of iodide are given acutely, the thyroid gland temporarily shuts down several hormone-related processes. This phenomenon is called the Wolff-Chaikoff effect. One of the most important acute actions is inhibition of thyroid hormone release from the gland. In thyroid storm, the thyroid already contains large stores of preformed T3 and T4 hormones. Iodide rapidly blocks the release of these stored hormones into the bloodstream. This helps lower circulating thyroid hormone activity more quickly during the emergency. Iodides also decrease thyroid gland vascularity, which becomes useful before thyroid surgery because it reduces bleeding risk. An important clinical detail involves timing. Iodide should only be administered after thionamides such as propylthiouracil or methimazole have already been started. Why does timing matter? Because if iodide is given first, the thyroid gland could potentially use the extra iodine to synthesize even more hormone. Thionamides block hormone synthesis, while iodides mainly block hormone release. Using them in the correct sequence is essential during thyroid storm management. Now let's briefly review why the other options are incorrect. Option A, increasing peripheral conversion of T4 to T3, is the opposite of what clinicians want. In fact, medications like propylthiouracil and propanolol help decrease T4 to T3 conversion. Option C, stimulating the sodium iodide symporter, does not describe the main therapeutic action of iodide in thyroid storm. The sodium iodide symporter normally transports iodide into thyroid follicular cells, but acute iodide therapy works primarily by suppressing hormone release. Option D, permanently destroying thyroid follicles, describes radioactive iodine therapy rather than Lugol solution. Radioactive iodine gradually destroys thyroid tissue over time, while Lugol solution produces a temporary physiologic suppression effect. This case highlights how endocrine emergencies often require multiple therapies targeting different steps of hormone physiology simultaneously. In thyroid storm, iodide therapy plays a critical role by rapidly inhibiting the release of preformed thyroid hormone, making answer B correct. This question focuses on a unique form of drug-induced thyroid dysfunction called central hypothyroidism. The correct answer is C, Barotin. Most cases of hypothyroidism occur because the thyroid gland itself fails to produce enough hormone. That is called primary hypothyroidism. In primary disease, TSH levels usually rise because the pituitary tries to stimulate the failing thyroid gland. But central hypothyroidism is different. In central hypothyroidism, the problem originates in the pituitary gland or hypothalamus rather than the thyroid itself. As a result, TSH production becomes inadequate, and the thyroid gland does not receive enough stimulation to produce normal T4 and T3 levels. Barotin is a medication well known for causing this exact pattern. Barotin is a retinoid drug used primarily in certain cancers, especially cutaneous T-cell lymphoma. Its endocrine effect occurs at the level of the pituitary gland. Specifically, Barotin suppresses transcription of the TSH-beta gene. This reduces TSH synthesis and secretion from pituitary thyrotroph cells. As TSH levels fall, thyroid hormone production also declines. Laboratory testing therefore often shows low free T4 together with low or inappropriately normal TSH levels. That pattern is the hallmark of central hypothyroidism. Patients may gradually develop fatigue, weight gain, cold intolerance, constipation, or slowed metabolism. Because TSH may not rise normally, diagnosis can sometimes be missed if clinicians only focus on TSH screening alone. Now let's briefly review the incorrect options. Option A, lithium, commonly causes hypothyroidism by inhibiting thyroid hormone release directly from the thyroid gland. That produces primary hypothyroidism rather than central hypothyroidism. Option B, amiodarone, can cause multiple thyroid disorders including iodine-induced hyperthyroidism, destructive thyroiditis, and hypothyroidism. However, it does not primarily act by suppressing TSH-beta gene transcription. Option D, sunitinib, is a tyrosine kinase inhibitor associated with thyroid gland injury and gland failure. Again, this produces primary thyroid dysfunction rather than pituitary suppression. This question highlights an important endocrine principle. Thyroid hormone regulation depends not only on the thyroid gland itself, but also on normal hypothalamic and pituitary signaling. Disorders affecting the pituitary can produce very different laboratory patterns compared with primary thyroid disease. That is why clinicians must interpret TSH and free T4 levels together, especially in patients taking medications known to affect central endocrine regulation. So, the medication known to cause central hypothyroidism by suppressing TSH-beta gene transcription is Barotin, making answer C correct. This question focuses on one of the most important biomarkers in endocrine oncology and thyroid cancer management. The correct answer is B, calcitonin. To understand why, we first need to understand what makes medullary thyroid cancer, often called MTC, different from other thyroid cancers. Most thyroid cancers arise from follicular thyroid cells, which are responsible for making thyroid hormones like T3 and T4. Medullary thyroid cancer is different because it develops from parafollicular C cells. These specialized neuroendocrine cells do not produce thyroid hormone. Instead, they produce calcitonin, a hormone involved in calcium regulation. Because medullary thyroid cancer originates from calcitonin-secreting C cells, tumor activity often leads to elevated blood calcitonin levels. That is why calcitonin becomes such a valuable clinical marker. Doctors use calcitonin both for diagnosis and for long-term monitoring after treatment. A markedly elevated calcitonin level may strongly suggest medullary thyroid carcinoma in the appropriate clinical setting. After surgery, calcitonin levels are followed closely to assess treatment success. If calcitonin levels fall dramatically or become undetectable, it may suggest successful tumor removal. If levels remain elevated or begin rising again, clinicians may worry about persistent disease, recurrence, or metastatic spread. Another useful marker in medullary thyroid cancer is carcinoembryonic antigen, often called CEA. Carcinoembryonic antigen can also help monitor disease progression, especially in advanced or recurrent cases. Medullary thyroid carcinoma may occur sporadically or as part of inherited syndromes linked to RET mutations. These inherited forms are especially associated with multiple endocrine neoplasia type 2, also called MEN2. Because of this genetic association, family screening and genetic counseling often become important parts of management. Now let's briefly review the incorrect answer choices. Option A, thyroglobulin, is mainly used to monitor differentiated thyroid cancers such as papillary and follicular thyroid carcinoma after thyroidectomy. It is not the primary biomarker for medullary thyroid carcinoma because C cells do not produce thyroglobulin. Option C, thyroid-stimulating immunoglobulin, or TSI, is associated with Graves' disease and hyperthyroidism rather than thyroid cancer monitoring. Option D, anti-TPO antibodies, are commonly used in autoimmune thyroid disease, especially Hashimoto thyroiditis. They help evaluate thyroid autoimmunity but are not tumor markers. This question highlights an important endocrine principle. Tumor biomarkers often reflect the normal function of the cell type from which the cancer originates. Since medullary thyroid carcinoma develops from calcitonin-producing C cells, calcitonin becomes the ideal marker for diagnosis and monitoring. So, the correct marker used for evaluation and monitoring of medullary thyroid cancer is calcitonin, making answer B correct. This question focuses on Graves' ophthalmopathy, one of the most distinctive and clinically important complications of Graves' disease. The correct answer is C, cigarette smoking. Graves' disease is an autoimmune disorder in which thyroid-stimulating immunoglobulins activate the TSH receptor and drive excessive thyroid hormone production. But Graves' disease does not only affect the thyroid gland. In some patients, the autoimmune process also targets tissues behind the eyes, producing Graves' ophthalmopathy, also called thyroid eye disease. This condition causes inflammation and expansion of the extraocular muscles and orbital connective tissue. As inflammation progresses, fat and soft tissue accumulate within the orbit. This pushes the eyeballs forward, leading to the classic appearance called exophthalmos or proptosis. Patients may also develop eye pain, redness, swelling, double vision, excessive tearing, and light sensitivity. In severe cases, compression of the optic nerve can threaten vision permanently. Among all modifiable risk factors, cigarette smoking is considered the most significant. Smoking dramatically increases both the risk of developing Graves' ophthalmopathy and the severity of disease progression. Smokers are also more likely to develop treatment-resistant eye disease. The exact mechanisms are still being studied, but smoking appears to worsen orbital inflammation, oxidative stress, and immune activation. It may also reduce oxygen delivery to orbital tissues and alter immune responses within the eye muscles and connective tissue. Importantly, smoking can reduce the effectiveness of treatments used for thyroid eye disease, including glucocorticoids and radioactive iodine management strategies. Even second-hand smoke exposure may increase disease risk. This is why smoking cessation becomes one of the most important non-pharmacologic interventions for patients with Graves' disease. Now let's briefly review the incorrect options. Option A, alcohol consumption, is not considered the major modifiable risk factor for Graves' ophthalmopathy. Option B, higher iodine intake, may influence thyroid hormone production in some thyroid disorders, but it is not the primary driver of thyroid eye disease progression. Option D, levothyroxine use, treats hypothyroidism and is not a recognized cause of Graves' ophthalmopathy. Another important clinical point involves radioactive iodine therapy. In some patients, radioactive iodine treatment for Graves' hyperthyroidism can temporarily worsen ophthalmopathy, especially in smokers. Because of this, clinicians may sometimes use glucocorticoids prophylactically in high-risk patients undergoing radioactive iodine treatment. This question highlights an important endocrine principle. Autoimmune diseases are often strongly influenced by environmental factors. In Graves' ophthalmopathy, smoking is one of the clearest examples of a modifiable exposure that significantly worsens disease outcomes. So, the most important modifiable risk factor for the development and progression of Graves' ophthalmopathy is cigarette smoking, making answer C correct.